Good evening, everyone, and welcome. My name is Jason. I'm one of the volunteer board members of the Pro Patria Centre here in Wagga. Tonight's session is When Medicine Meets Meaning, Psychedelic Treatments for Veterans with PTSD, a conversation that sits on the forward edge of mental health innovation in Australia. For a little housekeeping before we begin, if you have any questions throughout the session, please type them into the Q&A box at the bottom of the screen and we'll address them at the end. And importantly, as these topics can bring up strong emotions, please refer to the support numbers on your screen at any time, and please contact us after the presentation if you require any further support. It is with great admiration that I'd like to introduce tonight's speakers, Dr. Ted Cassidy and Mr. Luke Damon. Dr. Cassidy is a psychiatrist and Chief Medical Director of Monarch Mental Health Group. His driving vision is to improve mental health outcomes for veterans and Australians who have not found relief through traditional treatments. His special interests include PTSD, depression, and anxiety, and he works closely with Professor Paul Fitzgerald, Director at the Australian National University. Together, they are internationally recognised for pioneering next-step treatments in Australia, including TMS, esketamine, and, of course, psychedelic-assisted therapies. Dr. Cassidy's values are clear: use emerging evidence-based treatments to help more veterans regain stability, function, and quality of life. Our second speaker, Mr. Luke Damon, brings a powerful and deeply personal perspective. Luke is a veteran, executive, and lived experience advocate whose journey spans special forces service, senior leadership in financial services, and a profound recovery through psilocybin-assisted therapy. After experiencing combat loss, moral injury, and complex PTSD, Luke became the first veteran in Australia to legally access DVA-approved psychedelic-assisted treatment outside of clinical trials. His experience was transformative, and today he shares his story to highlight the importance of connection, culture, and leadership in frontline mental health. Luke is a strong advocate for safe, ethical, trauma-informed approaches and supports genuine healing and post-traumatic growth. Thank you both for sharing your time with us tonight, and I'll hand over to you, Dr. Cassidy, so we can all begin. Thank you.
All right. Hi everyone. Thanks for taking time on a Monday night to come and join us. And it's a great pleasure to be able to present here with people like Jason and Jackie, and to have Luke and share his story. I'm going to talk a bit about some of the structure of next step treatments and psychedelics in particular. Let me share my screen. Okay, let me just. There we are. So I'm going to talk about next step treatments, but clearly we're all here to talk about psychedelics. So really my discussions around next step treatments tonight are just going to be to place it in a bit of a context. So I want to talk about the landscape of next step treatments, because I think it's important, because I think the wrong way to look at psychedelic-assisted therapy is to look at it in isolation as a one-size-fits-all treatment for everyone. It really is part of an overall pathway. Then we'll get down into the detail of psychedelic-assisted therapy, what it is, how it works, what you can expect when you're having psychedelic-assisted therapy, what our experience at Monarch is in terms of looking at the overall numbers and outcomes we're getting from either psilocybin and MDMA. And then I think I'm going to hand over to Luke to discuss what the experience is going forward. I can't help thinking that for the people of this audience, it's a really important time, because the Department of Veterans Affairs has become the first mainstream funding body in the world to actually fund psychedelic-assisted therapy. So Australian veterans are really in the forefront of making these treatments accessible. Australia itself was in the forefront of making these treatments legal, and now Australian veterans are starting the journey of how this works within a funded treatment. And I can't help thinking, for my part, that the DVA has put an awful lot of responsibility in people like myself to make sure this is done properly. It really, I know everyone has their individual complaints about government offices, and in general I agree with you, but some of the people within DVA that have stuck their necks out, and they really have stuck their necks out to fund this treatment, are putting a lot of trust in people like myself, people like, and the general community to make sure this is done right. So I think let's make sure that it is done well. So first of all, as Jason said, I work with Monarch Mental Health Group, and my kind of personal mission has been to help people recover from mental illness. And as it's evolved over the last several years, really my exclusive area of practice is veterans and first responders. Probably about 70 to 80% of my practice at the moment is veterans, with the balance being first responders. The other passion that I've had is really about outpatient care, because unfortunately, a lot of the funding and a lot of the focus of healthcare is on what happens in a hospital. But the reality for everyone, for all of us, is that most of our life happens just outside of hospital. So if you can't treat people as an outpatient, you're probably not going to be able to sort of give them the outcomes that they want. Monarch itself is the largest outpatient provider of next step treatments. We've delivered probably around 40, a bit more than 40 now, of the 145 or so to 150 PAT treatments that have been delivered in Australia. And my interest in psychedelics was not wellness or lifestyle or kind of some of those kind of personal well-being things. It's much more as a treatment for depression, anxiety, and PTSD. These are key problems that have been there for people, and there are clear gaps in the treatment of these conditions, in that conventional treatment with drugs and psychotherapy only works for about 6 out of 10 people. So, a big focus of my career has been, how do you actually help the other 4 out of 10 get well? So, so what is the next step treatment algorithm? So what's the pathway that you go through? And I think this is a logical pathway for most people. Transcranial magnetic stimulation. So first step, I should say, which isn't on this drawing, is try a couple of antidepressants, see a psychologist. Most of that's done by GP, and most of the people on this call, I'm sure they've already gone for that. As I said, that works for 6 out of 10 people, doesn't work for the other 4 out of 10. The good news is, for the people it does work for, it's cheap, it's easy, it's a tablet, it's mostly well tolerated. So if you're one of that 6 out of 10, great. But if you're not, how do we get you well? What do we do for you? Because in the absence, if the plan is just to continue giving more medications, it probably won't work. So what makes something a next step treatment? Well, a next step treatment is something where the response you can expect from that treatment is not affected by the treatments you've had before. So TMS works for about 6 out of 10 people, whether you've been on no antidepressants or whether you've been on 20 antidepressants over 20 years. Esketamine Spravato similarly works for about 6 out of 10 people. Whether you've had TMS or antidepressants or whatever, even if those things haven't worked, you can still expect about 6 out of 10. And similarly with psychedelic-assisted therapy, it's probably around that 6 out of 10. So why does the arrow point in that direction? Well, it's really just, if they're all kind of 6 out of 10 treatments, and they all roughly, work, you can expect that 6 out of 10 no matter what other treatments you've had before. Why would you go in that order? Well, it's really just convenience. So TMS is cheaper than esketamine, which is cheaper than psychedelic-assisted therapy. TMS is more convenient than esketamine, which is more convenient than psychedelic-assisted therapy. TMS, you have a half-hour appointment, you can go about your business. Esketamine, you're out of action probably for the rest of the day. And psychedelic-assisted therapy is a really big commitment. You're probably in the dosing days going to spend 1 to 2 weeks sort of collecting yourself, getting yourself back on track. And there's going to be an awful lot of talking therapy that you're doing as well. In terms of our background at Monarch, within each of these areas, we've kind of been the first. So we were the first outpatient TMS treatment group in Australia. We now treat, I think the number's now up to about 40,000 sessions in 2025. So we treat a lot of patients. In esketamine, we were there as part of the initial rollout back in late 2019, 2020. And then we've kind of followed that journey through. And I think at the moment we're the largest provider of esketamine across our clinics. And in terms of the psychedelic-assisted therapy, Monarch's treated more patients than any other group. We've treated the first patients with psilocybin, the first patients with MDMA, and you'll hear from Luke, and we kind of got in and wanted to treat sort of veterans because that was really my sort of goal right from the word go, even in advance of the DVA stuff. So, Luke will tell you he had most of his treatment sort of late last year, early this year, well before sort of the mainstream DVA funding came on board. And these numbers, a little bit obscure, but this slide, but basically it's how I think it'll evolve. I still think that for most people, the first step is TMS, and for every 150 scripts, for want of a better word, I'll write for TMS. I think I'll probably be writing about 30 scripts for esketamine Spravato, and I might be treating 1 to 2 patients with psychedelic assisted therapy. So I think that's maybe that'll change over time as things get a bit easier, but I think that's the rough proportionality that I think will exist for the next few years. So, getting on to the exciting bit. What is psychedelic assisted therapy? So, both MDMA and psilocybin were approved for use in Australia from July 1, 2023. And as mentioned right up front, Australia was the first place in the world where these could be used for kind of mainstream clinical use. You didn't have to have a compassionate use scheme. You didn't have to join a clinical trial. But it is quite a complicated process. So the number of people in Australia at the moment that can prescribe these medications, I think it's about 40 at the moment in Australia that can prescribe, that are approved prescribers. And the process of becoming an approved prescriber means that you have to basically write down the protocol of how you're using this drug. So you can only use it in a very specific way and for very specific conditions. So there's not a lot of flexibility. And so one of the questions people ask me is, what about microdosing? What about take-home scripts or small doses? None of that is part of the approved prescriber scheme. So the approved prescriber scheme basically says you have to combine this medicine with therapy in a clinic situation and used in a very particular way. And we'll go through the exact detail of what that looks like. When the TGA approved these drugs, they basically approved MDMA assisted therapy for PTSD, and they approved psilocybin assisted therapy for treatment-resistant depression. They were very specific approvals. So you can only use MDMA if you have a diagnosis of PTSD. You can only use psilocybin if you have treatment-resistant depression. And in brackets, treatment-resistant depression means anyone who's tried 2 or more antidepressants and tried some psychological therapy. DVA, for their funding, has gone one step further. They've said that this is a 4th-line treatment. So in addition to the normal 2 antidepressants and psychological therapy, they're expecting you have some demonstration of a more intensive program. So that could mean multiple additional medications. It could mean long periods of care, or it could mean that you've tried TMS or esketamine as well. All of those are kind of valid sort of pathways from a DVA point of view towards getting for them doing their funding approval. And again, these treatments, by and large in Australia, are delivered in an outpatient environment. There's a little niche of kind of inpatient treatment, but by and large, this seems to have it seems to be evolving in a way where it will become an exclusively outpatient treatment, which fits in with what we do. The other thing about these medicines is both of these medicines don't work by themselves. The most important thing, and the bit that people miss, is you need to combine it with the therapy. So it really is exactly as Jason sort of indicated up front in the title. It's a kind of meaning-making medicines in a sense. You're using these drugs to augment the effect of therapy, and I think it's very powerful with that. What I notice with these treatments, in terms of the therapy process, is therapy, particularly with therapy for PTSD, it can be very unpredictable, very long, and very uncertain. And what you find when you're combining it with these drugs is that you can get a massive kind of acceleration in the effectiveness and predictability of therapy. And so my take on it was that, early on was that you can really do a lot more therapy in a lot shorter period of time and predict that you're going to have a good therapy day in a way that you just couldn't with anything else. Even things like EMDR, which I think for PTSD has been a bit of a mainstay. A lot of the practitioners I talk about who've used EMDR and are familiar with it are kind of saying, well, with, particularly with MDMA, you're going to get a much better response and a lot quicker. What do we know about MDMA and psilocybin? We know that both of these drugs have been around for a long time. We know that there's an incredible amount of recreational and off-label use of these drugs, and that gives us some really good data points. So one of the data points you get is that these are reasonably safe drugs. So that's really good. So, we know that if you look around in the community, there are not a lot of MDMA and psilocybin addicts. They don't seem to turn up in drug and alcohol units and addiction recovery units. And we know that they don't have a lot of kind of huge health problems either. They don't tend to turn up in emergency departments, with kind of, major kind of issues related to MDMA or psilocybin overdoses. So we know that's good. What we also know from the recreational use is they don't work for PTSD and depression by themselves. Because with all the people that are consuming MDMA and psilocybin, every weekend all over the world, if it was as simple as just the drug, then we wouldn't have a problem with depression and PTSD. They would have cured themselves, in the community without the assistance. So it's certainly, there's some good news from the community use, there's some bad news, but I think the community use reinforces the model that this is therapy, and it's a way of making therapy work better. So what does the therapy look like? So again, remember I said up front that the TGA has not approved a drug, so I can't just go and write a script for this drug. What they've approved is an entire process. So they've said, if someone's following this process from A to Z, then you can use this drug at the various points and the various doses along the way. So what process have they approved? So they've approved a process by which someone comes into the program and they have an initial assessment, and they by both the psychiatrist and by the therapy team. There's a whole range of screening that has to happen. You have to talk to the GP. You have to have various referral forms. You have to collect a whole bunch of data along the way to sort of, demonstrate where the starting point is for someone. All of that is prescribed. You have to do it in that way and that function. Then once you've said that someone's eligible for treatment, and, beyond the sort of positive indications, so we know that if you've got treatment-resistant depression, you can sort of, be prescribed psilocybin-assisted therapy or PTSD MDMA, but who can't? So, someone who's had a history of psychosis, someone who's had a history of recent significant drug use, they're going to be problem areas. Someone who has a history of bipolar disorder, that can be a relative contraindication. Someone who's not, and this is a bit more subjective, someone who's never really thought about therapy, someone who's not really interested in talking therapy. I think the best candidates for this treatment from a therapy point of view are people that have made numerous attempts over the years to do therapy. They have a great theoretical understanding of it, but it just hasn't connected with them personally. It just hasn't felt right. They know what they're meant to do, and people have told them and they've paid attention, but it just hasn't landed for them. That's a very good candidate. And the other big problem with these treatments, and it's not really a contraindication, but it is an issue between that initial assessment and the preparation, is you've got to come off your SSRIs and your SNRIs. And these are the medications, the antidepressant medications, which we've already said don't work completely, but which inevitably most people find is that they've worked a little bit. They didn't do nothing. They did something. They just didn't do enough. And so that can be a tricky thing. You're taking someone off something, so they may well get a little bit worse. You need to be off the medications for at least a month, and in truth, probably the more the better. So that can be a difficult period that we have to negotiate, the withdrawal symptoms and coping with any relapse of depression. That's one of the trickiest periods. Once you've got through that, then you are connected with your therapy team, and it's usually 2 therapists. You have 3 to 4 preparation sessions where you set the goals for therapy, discuss what you want to achieve. There's a bit of a kind of deepening relationship between yourself as the patient and with the therapy team. And then once you've done that, usually over about a month, you have your first dosing day. And the drugs are different, but the sort of pattern falls the same. It's basically a kind of 9 to 5, 8:30 to 5:30, 6 o'clock sort of day. You come in, you meet with the therapy team. There's usually a bit of grounding, just introduction to the room, and then you'll be given the medicine, either psilocybin or MDMA. And most people, it takes sort of anywhere from about 20 minutes to an hour and a half to work, with the majority of people around that 30 to 40 minutes noticing some effect. And the effects can be quite different. If it's an MDMA dosing day, what people find is that their fear centers are just switched off. So all that kind of trepidation, shame, all the things that have been holding back a discussion, all that sort of stuff just sort of washes away temporarily. And people find themselves much more able to connect with their therapy team than ever before. With psilocybin, it's a bit different. It's a much more internal experience. It's an experience whereby you have an internal journey. It's a much more abstract experience, and within the dosing day itself, the conversations tend to be a lot more limited. And in those cases, for psilocybin, it's a much more about the making meaning following the sessions, drawing together the various insights and abstract connections. And I'll leave Luke to sort of talk about that a bit more. Following that dose day, you then do another 3 to 4 individual sessions with the therapist, where there's a sort of breaking down, a sort of making meaning of what happened within the dosing days. And then you repeat the process. You have a second dosing day, very similar, usually separated by a month, another 3 integration sessions, follow-up sessions, 3 to 4 follow-up sessions, and then a third dosing day. So for both psilocybin and MDMA, we have 3 dosing days. The whole course of treatment tends to be around a 3.5 to 4 month process, can be a bit longer. I actually think it's probably sometimes better to be a bit longer, but usually most people want to do it a bit faster. So it's kind of, there's a bit of a tension there. Probably the fastest we can do it is 3 weeks between each dosing day. That's the absolute maximum of speed we can do it, based on the protocols. So that's what it looks like. So we collect a lot of data. This is just a busy slide. So this is sort of my plug for we're linked in with the Australian National University Psychedelic-Assisted Therapy sort of outcome register. So that's a national register where they collect the data. And so that's a great sort of way of both individually tracking patients and also putting all the data together so that as a country we have a chance of actually being able to demonstrate the effectiveness of these treatments. So what have we found for psilocybin? This is my, and I'm not going to spend too much time on this, but my overall take, so with psilocybin, that it's quite an unconventional therapy. So it feels like you're doing something different, both from the therapist, and there's a lot of kind of internal exploration that happens on the day. And from the therapist point of view, you're often wondering what happens, and you're trying to catch up on the events afterwards. Transformative experiences certainly happen for a number of patients, but it is very difficult. And by and large, I find the kinds of people that come into medical programs tend to be a bit more anxious. They tend to be a bit more perfectionistic. They don't want to do something that's underground or illegal. So the levels of anxiety tend to be a lot higher. And one of the hardest things about psilocybin is letting go. And often there's this incredible sense of being unable to hold on. And people can find that process, particularly on the first dosing day, early in the dosing day, that can be a really difficult and tricky time. And I've certainly seen people experience significant distress. I think that can be ameliorated by doing a lot more preparation. Overall, my long-term take on this treatment is knowing people a bit better and doing much more and much better quality preparation reduces these risks. And the second thing is, there's realistically, I suppose, there's less data on psilocybin than MDMA. So it's really important we sign up for things like the ANU register so that we can really get a sense of how sustained these improvements are over the long term. So I'll look at some of our outcomes. This is our 2024 outcomes. So it was 8 people had psilocybin in 2024. And overall, you're looking at a significant improvement from beginning to end. You're seeing from baseline to the 3 to 4 month process after the baseline, you're seeing people improving. There's a little bit of backsliding that we're seeing kind of in the 3 to 9 months following. There's some longer term data on this. People settle down in a better position than they were, but you do get a little bit of backsliding. Now that's psilocybin for depression, and depression's quite hard. The other thing I've noticed with psilocybin, which is sort of off the reason why we use it, is there does seem to be a kind of change of attitude to how people kind of view themselves and their body and their place in the world. And I see this particularly sort of flow out into in terms of addictive behavior and even kind of that sort of more general sort of impulse seeking behavior. People find themselves after psilocybin less likely to drink coffee, or they drink less of it, or they just want to exercise a bit more, or they don't want to eat as much meat. There's a lot of these little stories. It's very hard to sort of quantify it, but there's a lot of stories that just generally, fit into the general category of my body's a temple now and I better look after it and I better take a bit more care. There's a lot of that. Those sort of patterns with psilocybin kind of follow through. Across kind of all the different rating scales. So MDMA. MDMA is really, really interesting. There was a bit more data up front with MDMA and PTSD, even prior to the sort of rescheduling. And the results in MDMA assisted therapy, from my observation, are absolutely remarkable, really. It combines um, a predictable and fairly conventional treatment approach, which makes it easier from the therapist point of view and much easier to prepare people, with outcomes that seem to be really kind of tremendous, really. I mean, I've never seen something work as well with PTSD than MDMA assisted therapy. It does seem that for people that have really struggled to make the emotional connections and land the emotional connections between their trauma and the therapies they've tried, that MDMA is a great facilitator of this. And what I find with people is that they can make changes within the dosing days that then allow them to um, sort of almost self-sustain those changes down the track. They almost can start to sort of pull together all the kind of therapy threads that they've been exposed to as within their own day-to-day life. And so their actual needs for medications and ongoing therapist contact is a lot less, after the treatment than before. It's fairly conventional. It's very safe. No adverse reactions. You don't have that same sort of letting go effect that you have with psilocybin. That can be difficult for people. Minimal preparation, fairly sustained benefits. I actually kind of, I've kind of had a number of patients who I've started their sort of psychedelic assisted therapy process with MDMA therapy and then later on have gone on to psilocybin assisted therapy. I found that sort of combination, particularly when someone has a lot of anxiety, I found that to work quite well. And again, similar sorts of numbers in 2024. We had about 10 patients. And the interesting thing with, and this was across all, I'll show you a whole bunch of graphs, but this is what I saw across MDMA, and it always looked like this. You get better from beginning to end, and then you just kind of keep on getting better. So, you look at the data, better over a 3 to 4 month period. And you could argue that a lot of people would get better if you spend, I mean, the actual therapy time, if you add up all, if you look at that graph that I have of the time you're doing things, you're probably getting about 80 hours of therapist time over a 3.5 to 4 month time. So it's quite a lot of therapy. So you kind of expect that people would get a little bit better if there's some good therapists doing all this work. But the really interesting thing is that they just keep on getting better. So I think this is, I was on a panel with Pat McGorry, the guy from Headspace, who, is a kind of a sort of well-known psychedelic assisted therapy skeptic. And his view about MDMA therapy was that it was, had all the hallmarks of a breakthrough therapy, which I agree with. Similar, and across all the different things that we use to measure depression, DAS scores and, various other rating scales, same pattern, better from beginning to end, and then just keep on getting better. So this is the perfect segue into a case study where we talk about the real thing. I'm not going to show you any more data. I might stop my screen share here. And I mean, I'll let Luke introduce himself, but it was a great pleasure working with Luke over the course of last year and early this year, and it's been a real privilege to see him progress. And at this point, I think I'm just going to step back and let Luke take over.
Thank you, Ted. Can I just get a thumbs up from you, Ted, that you can hear me? And if my screen started sharing?
Yep. Yes.
All right. Look, what a bit of an act to follow there, Ted. It's an interesting take to be on the other side, and to have this type of conversation now compared to where we were. Look, a year ago when we started this journey, for the first dosing session, which was in December last year. So it's coming on the first anniversary for the first treatment. So I feel very well supported to be here. But for those people who are on the line, I know that we've got a mix of veterans and clinicians on the line. Look, I'm going to tell my story to some extent. I'm going to try and keep it wave tops. I don't want to bring things up for people, but it's okay if you want to step away, if this brings up anything for you. But like my story here is a vehicle, and it's a vehicle of hope, from my own experience. So I hope that comes through in today's session, and please feel free to ask questions of Ted and I throughout. So look, I'm going to take you through my story. So as Jace alluded to at the start, yes, I did serve for a number of years, 13 in total, mostly full time, and at the back end there part time. I'm going to take you through that journey. My story is just an example, one example. And again, to that point, tonight is about hope and community, and what can be possible for veterans and clinicians when you work together in the right way to get to an outcome. The priority here is not for me to tell the story, but to try and educate the group on what this treatment looks like. So moving straight through, my service life started in 2005. You've got chevrons across the top there. I'll attempt to breeze through this quite quickly, but I enlisted as an officer. I went to Royal Military College in 2005. It's a leadership training organization for those who don't know. So straight out of school, really, after traveling the world backpacking, I joined up. And graduated after the 18-month course in first in class for leadership, commencing my career into the regular army, initially into the Royal Australian Infantry Corps and 3rd Battalion, for those infantrymen, if there's any on the line. I deployed straight away as a 20-year-old, where I met my platoon in country into East Timor on Op Astute, and sort of rounded out my time as a platoon commander at 3 Area, and set my sights on special operations. So I commenced special operations, the commando selection and training in 2011. Now, for those of you who don't know, this is an arduous course. There's a very high failure rate, and roughly you get in the thousands of applicants per year. And at the end of a 1 year selection and training cycle, we graduated with 19 at the very end. So it's quite a grueling process, but it's basically sets you up over a series of courses over a year, and selection throughout, to deploy on operations straight away. I'd say I was very young at this stage in terms of my frontal lobe development. I was 25 as a special operations officer, as a captain, deploying moving straight into Alpha Company in 2nd Commando Regiment, and who were on Tactical Operations Group East when I moved into that unit. I rolled straight out of selection into preparation for Afghanistan. Look, and this for a young Australian male serving his country, it was a highlight of my career, but it came with its challenges. It was difficult. We sustained casualties, which were very, very hard, and hit the community very, very in a big way. And essentially, that really I didn't pick up on it at the time, but that really started, I guess, the instances of where PTS and the like started for me. I at that point in time identified that a long-term career in the military wasn't something that I was going to be able to handle long term, particularly wanting to start a family and get married and the like. And so with my career in special forces, deployments, the operational losses, and then the non-combat losses coming through within the community hit me very hard and started getting me to focus on transitioning out of the military and from an operational environment that was so high tempo, where I didn't spend any time at home, to also doing the deployments and high tempo environment and studying a Master's of Business and a Master's of Project Management to secure my transition out. And at this point in time, towards 2018, when my first child was born, I nearly finished my my degrees, moved into the 1st Commando Regiment and was ready to transition. So transitioning for service for me, I had a plan, I had a career path, I had a family at this point who I like that I adored. I still adore them, and but inside I carried like an invisible rucksack of unresolved grief, unaddressed pain, physical injuries. And so from the outside, the next chapter looked like everything had worked. And on the inside, those unresolved parts kept shaping my thoughts, reactions, and relationships around me. So my screen's frozen. There we go. So my transition involved me moving out of one high operational tempo environment to having 2 kids and moving into another high operational tempo environment, straight into financial services, initially starting at National Australia Bank and then moving into Macquarie. I took on quite senior roles in strategy and transformation, and my life as a husband and father is what I adored. Outwardly, I was successful, and that's what I prided myself on. I thought that success and achievement is what was defining me, but inwardly, I was unraveling. Physical injury, and the cognitive load of what I'd been through previously, and it really did become a difficult time for me in that transition, trying to find my new identity post-military service, which is a very common thread for people who are exiting the uniform. And this is a really hard part for veterans, where we see that success is masking the suffering. But I felt really disconnected from my family and from those around me, and myself. And really that started the decline for me in 2012, where my physical ailments got a little bit too much for me. Behind the armor that I was pushing out on the exterior, there was complex PTSD and major depression. Around this time, there was the Brereton inquiry into Special Forces actions in Afghanistan, where we were all called in for questioning, and it really brought up things like moral injury, and questioning and second guessing things that we'd done over the time. And this also coincided with COVID, the transition pressures, family loads, and my mental health sort of deterioration over this time. The coping strategies that I had through physical fitness, control, discipline, and pushing harder stopped working for me. And this became a couple of years of sort of profound depression and managing complex PTSD. I started the pharmacology pathway here, where I was placed on an SSRI. Initially, that didn't work. Moved to an SNRI, which it put me in hospital for 6 weeks. Moved to a different antidepressant, which didn't work, and then another antidepressant that didn't work. And realistically, when I say it didn't work, there were times when I couldn't get out of bed before 11 a.m. I felt like I was wrapped up in bubbles. I didn't have any feelings and the like. And so really, it's not that from the clinicians on the line here, and from a guideline perspective, I was well supported and the intentions were right, but the care that I was receiving just wasn't breaking through for me, and wasn't making lasting change, uh, and the like. So I'd like to sort of say that there's hope for healing in this part, and I'd like to sort of dive into now where the decline sort of shifted for me. And it comes around that time that in 2023 that Ted mentioned, when the TGA legalized psychedelics. I was quite connected into our US Special Forces community, where a number of them were going to other countries to receive treatments. And anecdotally, I was hearing of the profound impact that brothers and sisters in arms from overseas had been receiving from these treatments. Look, I started my reading, like Michael Pollan's Netflix series, or his book on how to change your mind, was really interesting. Heroic Hearts is another organization similar to Pro Patria, just wonderful sort of community and people who were really starting to challenge my negative thought patterns around there is no hope. And one of those elements was another book, the Veteran's Guide to Psychedelics. I started reading far and wide and petitioning the DDA for veteran access, which led me to find Ted, and Monica and Monarch, and so. I was after a legal, supervised and structured pathway to receive these treatments. I was in no headspace to head overseas or to do anything else in that vein. And we reached an agreement and a time and space prior to the Department of Veteran Affairs approving this, that I wanted to go down this pathway. And it felt like it was something that I didn't take lightly in terms of how I chose this pathway, coming from an environment where you're drug tested every week, within the military, or when you're on operations in Afghanistan, and you're looking for drug labs. Like it's quite a lot to battle with, to decide to come to take this pathway and to see the medicines in a different way, which is a profound shift change that I've had since. Now Ted had a different slide, but my slide essentially says the same thing. So this is what I call the treatment container, of preparation, the dosing sessions, and integration. And I want to talk a little bit about my experience, of working with Ted and Monica and Monarch, and that time for me. This was absolutely life-changing. From 12 months ago, Ted, to doses 2 and 3. The shift change that I had from dose 1, and going through this process, that Ted, I won't harp on it, or go into much more detail than Ted did before, but there's an entry. There's an entry to the little circle I've got there, which is the assessment and sort of funding pathway, and then preparation, dosing, integration, and I went through that cycle 3 times. And I'll just take you through some of the things that I found really important within, because Ted's already covered the detail, but really important in the preparation and dosing phase. The reason why there's pictures on the side here is these are some of the things that I brought into the dosing day with me. It's not something like again, like coming from the military background of commandos and that environment. A coloring book, journals, meditation beads. You can see Toad from Mario Kart there, because he's a cool little dude and he's a mushroom. Like these were the things that came to me that I wanted to bring photos of my wife and kids and memorial bands for the fallen. I lent on these throughout the journey, and it was the safety and the relationship that I was able to build with the practitioners in the room with me that was so profoundly important because I've got some quotes sort of littered throughout this, but safety is not the absence of threat, it's the presence of connection. And so the connection that I was able to build with Monica and Ted to feel safe and let go, as Ted mentioned, within these dosing sessions was pivotal. And so I had the standard 3 to 4 preparation sessions, but because we were in that environment of negotiating with Department of Veteran Affairs and talking with them, we actually had a bit of a longer lead in, which enabled us to build a little bit of a deeper relationship prior to going in, which I think is one of the critical things that was really led to the success, particularly the first dosing day and the like. So in terms of the preparations here, they helped establish that psychological safety, clarity, and intention. I had regular preparation sessions, both with Ted and Monica together and separately. I started a journaling practice. We set our intentions. I used some fantastic apps like the Sam Harris Waking Up app. I started reading a lot more and a little bit more abstract than I have done in the past, like Aldous Huxley's Doors of Perception. Just things that were trying to expand my mind a little bit. And something that Ted said that really resonated with me is that I've had so much theory through the psychotherapy sessions that I've had throughout the years of that decline, that I was able to start bringing all of that theory together and sort of repackage it, ready to let's use this. It was profoundly helpful. And again, in that preparation, reducing commitments, clearing that emotional space, spending time in nature, like yoga practices, and gentle, soft movements. For the dosing day itself, like I spoke about some of the things that I brought with me, but I actually felt a huge calling to write about my experiences in a lot of depth. And writing about those experiences enabled me to do some really fun things in integration, which I'll highlight a little bit later. But perhaps I'll talk about some of the experiences now, a little glimpse into the journeys itself. So 3 sort of core themes came out for me about meeting grief, remembering love, and seeing a bigger picture. And so to share a few moments of those, not necessarily the visuals, because there really are no words to describe what the visuals provided me, particularly in the first dosing session. Like, honestly, words don't do it justice, and you start explaining it, and then you realize quite quickly how much you're butchering it. So it's hard to describe. It's not a spectacle, but there are emotional truths that surface throughout. And for me, this meeting grief was about the first time in my life that I felt the full weight of grief. I allowed myself to grieve in those internally sessions. Now, when Ted said it's an internal thing, I pretty much lied there under a weighted blanket with noise cancelling headphones and a mask on from about 9 a.m. till 3 or 4, other than getting up to go to the bathroom, which were really interesting experiences as well. So we didn't really chat much throughout the day, but in that time, I experienced the full gamut of grief. I met the fallen and experienced that, and it was quite profound, and it was really one of the most significant moments for me. And how much I'd carried over the previous decade through the losses, the decisions, the weight of command and leadership, and the ways that I felt that I'd failed people that I'd led or loved. And then in everyday life, I couldn't go near those emotions without shutting down or being numb. But under that right support, I could finally let myself feel it rather than being overwhelmed. That moment didn't necessarily fix anything, but it broke through the belief that my pain was untouchable, and that it was the beginning of healing. So like my message to clinicians that are on the line, this containment, what we spoke about before of the preparation, dosing, and integration is so important. It matters so much because feeling grief in a safe and relational field transforms it from trauma to integration. And for the vets that are on the line, you don't break by feeling things, you break by holding it inside to yourself. So that was what feeling grief was like for me. Remembering love, this ended up becoming the anchor for me. I felt like I couldn't feel love prior to this, and feeling the love for my wife and kids, not as the idea, but as an embodied moment for me. PTSD had numbed it for years, and here it cleared the static. No longer was it wrapping everything in a distance. I was able to see family, fallen, friends, all sorts. I could see them quite clearly and how much love connected us. And it was such a strong, wonderful feeling. And for the first time in many years, I could feel myself as a father and a husband and as a leader, not in a performance mode, but just being present and being able to be that person was really quite wonderful. And this came out for me in my journaling practices afterwards and through additional therapy and yoga and the like, and slowing down. It was about nurturing that connection and having that, if you could imagine experiencing something in the eyes of a child for the first time, and the awe and wonder that comes with that is how I would describe the feeling and experience that sort of came here. And again, to clinicians, veterans, for Medevac veterans, love is not blocked intellectually; it's blocked somatically, and that when we change those emotional channels, we can reopen them, and then that therapeutic trajectory shifts. For vets, you haven't lost that capacity for love, and it's still there underneath the armor. And so these dosing sessions really broke that armor down for me. They're seeing a bigger picture. This allowed me to see myself not as the villain of my own story or the victim or being the broken veteran or someone who had succumbed to mental health issues or physical health issues and had to go on antidepressants and had been in hospital and had some horrible thoughts at a time. I was able to move past all of that and see myself as a human in the context of just broader society and really, like, there was some wonderful experiences that happened. Don't need to go into detail into them, but really that shift allowed me to rebuild an identity that I thought I'd lost to war and trauma and performance, but I was able to replace it with connection, humility, and service and the like. So yeah, that's like a little snapshot, and looks. The experiences between doses 1, 2, and 3, you don't know what you're going to get. You really don't. Yeah, and they were so dissimilar to each other. They were very, very different experiences. First one was very eye-opening. Second one was very heavy, and third one was just like a lovely balance that really finished things out. But nothing I would have expected in leading this. So integration is the part here. And I've thrown a couple in there because medicine, like, you are the medicine. As Ted said, plenty of people out and take these medicines, but unless you're willing to do the work, and unless you do the work, you don't get the outcomes that are available. And integration for me was ongoing sessions. With my care team, I've got Monica there and Ted, but like the therapeutic sort of pathway. I'll talk in a moment how that has changed. So from years of having therapy about PTSD and depression and nightmares and window of opportunity after these dosing sessions to challenge the automatic thought processes that you go through. And I did that through journaling. So when these automatic negative thoughts, or you might think of cognitive behavioral therapy or acceptance therapy, whatever you want to lately I used all of these sort of tools either in therapy or outside via journaling, where I would write about them and then I would challenge myself. And I could see the narratives changing day on day in the journaling activities that I was doing. I got into a lot more yoga movement. I started seeing an exercise physiologist and getting back to being healthy again. My diet cleaned up. In the last year, I've lost 10 kilos, maybe a little bit from medicines, but not being on antidepressants. But look, I'm just so much healthier. But slowing down and changing those habits. But what helped most was consistency, having the right support network around you, and being involved in community and not isolating yourself in this time. Now, I hope I haven't sort of put this up as a panacea or fix everything. There's a lovely book that I'm reading at the moment by Jack Cornfield called After the Ecstasy, the Laundry. It's a wonderful sort of take on, yes, you can have these profound transformative experiences, but by gosh, two young kids really produce a lot of laundry. You've got to get back to day-to-day life. And it's how you integrate the things that you experience, the insights, the learnings, how you translate that into day-to-day life. I'd say that, like, from a SUDS, my subjective experience, mirrors the clinical results that Ted mentioned, probably more from the MDMA pathway than from the psilocybin pathway. But you know, these negative thoughts that I've had about my life or experiences have really moved on. I'm present with my family. I'm way more involved, with the kids. I feel like I've found my old self. I've got a capacity to work. Like I might have mentioned it in that decline period, but I had to stop work, and I stopped work for 2 years. I went on sick leave for 2 years because there was just no hope for me working throughout this time. And I have now, believe I got like capacity to sort of reconnect and give again, and the ability to feel joy and meaning. But what's still there? There's still vulnerability. There's still triggers. It hasn't like removed things completely, and there is a need for ongoing support. And there were some system battles that Ted and I went through afterwards around the funding and getting DVA to the point that where we are today. But I'm profoundly proud of that sort of advocacy piece and the hope that this provides the veteran community and how many people that it can help, hopefully help. Well, I spoke just before about how therapies change. Therapy is no longer talking about depression and PTSD and triggers. It's about how do I become a better father? How do I reintegrate into a workplace? That shift change is just phenomenal. It's like I now have ownership of my trajectory moving forward. So if I was to just close on two last final slides here. So if you're a veteran, healing is not on the line here. Healing is not a linear process. You're not alone. And I can't sort of say that enough. Like you're really not alone. There are so many avenues and organizations, and whether this pathways becomes a pathway for you, I feel incredibly privileged to have been able to have this pathway. But whether you are on this path or not, you're not alone. And if you're feeling like nothing works, it doesn't mean that nothing will work. They're not shortcuts, these therapies, and they're not for everybody, but the right team and container and community can be everything, okay? And that you can be the medicine. For the clinicians on the line, so your presence and honesty matter just as much as the protocol that you're following and that relationship that you build with veterans, first responders, whoever it might be. Veterans need to see you as a whole person, not just risk and diagnosis. So it's not about, pardon me, delivering a script and sending you on your merry way or delivering a dosing day and a few mandatory preparation or integration sessions. Like they need you. And that preparation and integration time are not optional extras. I feel without them, it very much could be back on the merry-go-round. And you can build systems that make this. You need to build those systems to make this accessible without burning the clinicians out. Ted mentioned how many hours there are in one patient. I don't think that there would be another patient in your portfolio of patients that you would spend this amount of time with. So you will build relationships with these people, but make sure you don't take on their burdens as your own and don't burn out, because there are a huge number of people who need you. So that's thank you. That's my story. I wonder, Jason, have any questions popped up while we've been going? I'll stop sharing.
Yeah, awesome, Luke. Thank you so much. And thanks, Dr. Cassidy. You've both done an incredible job sharing your experiences. And in particular, Luke, thanks, man, because I know a lot of people listening, including myself, get a lot out of hearing other people. And there's a lot of similarities in a lot of our journey. So for you to be able to share that and create that new pathway for people, that's incredibly powerful. We will open up to questions. So if you do have any, you can chuck them in the chat. I've got a couple up here to kick off. First question is probably directed at you, Ted. Someone living in regional New South Wales, South Coast, they've asked if they get approved for MDMA therapy and it's in a major city, is DVA going to support them to bring a carer with them? Is that included in the funding, or how would that work?
Yeah, I mean, look, the answer is I don't know, because I don't know. I'm not sure the DVA's funded the first person yet. I do think they're realistic about how these things work. I think having a carer is absolutely fundamental. It's built into the protocol that a carer has to be kind of drop you off, pick you up, be available on the night of the therapy. I've certainly had no issues with DVA funding people who are coming from rural areas from TMS or esketamine. And I think the case for that funding is probably lower than it is with psychedelic assisted therapy. So uh,
Mm,
it would surprise me if there's an issue.
yeah. And I think it's important too to include those carers or those family members in that journey as well, and probably from that first appointment to the very last one.
Yeah.
I think, and Jason, just to sort of tap onto that, Ted, Ted and Monica ran a session with my wife and I around what was the journey that I was about to embark on, how she could support me, what are some of the changes that she might see, what was her role in coming down to Melbourne was when we first started TED for the first two, and then into Sydney when New South Wales opened up in March. But my wife travelled with me for those and was included in the packet. But again, I was dealt with in a different pathway to the existing model that's just been released now. But yeah, having your partner or support person and those around you is really critical to them understanding that you need a little bit of space after these treatments.
Awesome. I've got another question here from someone, and again, it's probably one for you, Dr. Cassidy, to do with dosing. Someone's asked what kind of doses are involved. I'm assuming they mean if it's a smaller dose or a larger dose, is
Yeah.
it dependent on the person?
I've just recently sort of updated my protocol, but when I treated Luke, the range for psilocybin was 25 to 30 milligrams. There wasn't really a lot of flexibility. It was just based around weight. Um, and um, and then for MDMA, the dose was 180 milligrams, usually given as a divided dose of 120, and then an hour break, and then another 60. So, having said that, in my most recent sort of update to the TGA approval, I've got a much bigger range now, 15 to 40 milligrams. It tends to be that people that are very anxious, have a lot of anxiety, are probably better off starting with a lower dose. Probably 25 is okay, but you may even have a case for 15. Now, 15, the problem with 15 milligrams is it's unlikely to be a true psychedelic dose. So, the only reason you give someone 15 is if you thought they were very, very anxious and you just want them to have a dosing day and a good experience with the intention of increasing it. Similarly, people who don't have a lot of anxiety, but just a much more sort of profound sort of depression, tend to do a bit better on the higher doses. So, hence the sort of 30 to 40 milligram range we have now. So a bit more individualized these days than it was before.
Beautiful. And I've got another question here. What are the first steps for a patient to connect with an approved provider? So again, Dr. Cassidy, you could probably answer that with Monarch Mental Health Group.
Yeah. I think, look, the first thing is, contact, contact someone who provides it. So Monarch would be a good start. But I think have a discussion with your GP as well. I mean, that's a really logical place to talk. Talk to your GP. You're going to find that your GPs, by and large, don't have a lot of information about this treatment, but it's great to have a GP on board. And, part of the assessment process will be, the approved prescriber and the team actually feeding back to your GP, talking to them, bringing them along on the journey. If people have got a treating psychiatrist, all the better. Ideally, if people also have a psychologist or a therapist they're seeing, that's actually a really good asset, because those people are people that you can see before, during, and after the treatment.
Beautiful. Luke, I've got a question for you. How long were you out of action after doses, driving and function wise?
Um, so I received a little safety letter from Ted and the team, and I wasn't allowed to drive for 2 days. I think that just from a safety perspective, um, realistically, I'd say that definitely the day of and even the day after, you're just a bit spacey. Like it's not that you don't have, or I'm talking the day after now. It's not that you don't have full functionality, but you're just you take a lot more time doing things. You're a lot more intentional. I'd say that your reflexes are a bit slower and you're much more thoughtful. That could pose issues, I guess, of driving. So I think definitely, Ted, I'm not sure what your sort of from a clinical side, what your recommendation would be or what the guidance is now. But before you sort of answer that, what I would say to you is that you don't want to be going straight back to work. Like if you have a really profound experience and even like sometimes you don't even know what was that, what happened. And if
Mm.
you go back to work, you're just going to go back to your you're not or if you're going to jump straight back in, you're not making the most of like that those neurological pathways that are now open to you to rewire and recreate and regenerate habits. So if you can take some time off and try and live the habits that you'd like to have. So if you can have a carer drive you for the next 2 days, if you need to go somewhere, if you can stay away from work for I don't know like a week, that would be my recommendation personally from having experienced
Yeah.
it.
Yeah, no, nothing much changed, Luke. I would totally agree with that. I think the driving is kind of an interesting one. I think that sort of 24, 48 hours is fine. But I think the most important thing is this is an experience that needs to be sort of considered and worked out, and you need time to actually make it, unpack it. And so you absolutely need that week off afterwards. I'm pretty well telling everyone, schedule a week. And this is actually one of the limitations. Remember, I said right up front when you're looking at next step medications, this is a time-consuming treatment. I mean, there's a lot of therapy, but you've also got to create space in your own life. Over a 3.5 month, 4 month period, you're probably going to be taking a month out where you're just going to be doing kind of self-care, spending as much time in kind of more meditative, thoughtful times, spending time in nature, spending time kind of looking after yourself and allowing yourself to not be super reactive. Like the problem with work and big conversations and all these kind of deeper meaningfuls with people around you is that you can become very reactive to other people and other situations, whereas this is a really important time where you've got to see what comes up. You've got to see how, what is this kind of really different, sort of hard to describe experience? How does that work itself through for me? And there's no surprise that when you look at sort of the history of psilocybin in particular, there's a big association between psilocybin and spending a lot of time in nature afterwards. It's kind of makes sense.
Definitely something to be said for that, for sure. I've got another question here about, sorry, Michelle. So how is it decided when to have single or multiple dosing days?
Well, I mean, we don't get a lot of decision because the approved pathway is 3 dosing days over 3.5 months with three prep and then three integration after each dosing day. That's the pathway. Now, having said that, of course, it doesn't work that way because if someone has one dosing day and they hate it, then the option is there to pull out. So I think not everyone has 3 dosing days, but I think everyone kind of starts the process with a kind of 3 dosing day map ahead of them. And, that doesn't work out for everybody or isn't needed
Mm.
for them.
Beautiful. And I think we've got one more question here, and I think it's an incredible reflection on the lack of questions on how well a job you both did on explaining what's happening. But we've got a good question about workplace drug testing. So what are the implications now with these new medicines if someone is in their workplace, and how is that kind of looked at?
Yeah, look, it's not going to hang around in your system. It's certainly not like cannabis where, you're going to have sort of, it's going to be in your system for weeks or months. And following on from what we said, I mean, I think you probably should be booking a week off work anyway. But,
Mm.
these are fairly short half-lives in your system. So within days, they're going to be unmeasurable. Yeah.
I do have one more question too, and it's about the follow-up. Is there a follow-up treatment post the 3 month period, and how long are the follow-ups included in the actual therapy?
So the actual therapy is as described. So it's almost like this kind of beginning and end point. In reality, at this early stage, and people like Luke and sort of other people, we've kind of once you get to know someone so well, once you've spent 80 hours with someone, or 40 hours as an individual, people tend to know each other quite well. So it becomes quite easy to follow people up. And there's a lot of, yeah, it's just a lot easier to do. What I would say to the people that are kind of treating doctors or therapists on this line is if you have patients that are suitable for this treatment, if you can find some way to be one of the therapy team, I think that's a great thing to do, to be honest with you. It may not mean that you're treating 100 patients a year, you may only treat two or three. But if they're patients that you already know and you continue to see them, your work's a lot easier. It's going to be, a much more enriching experience for everyone.
Mhm. All right. All right, and we just got some thank yous in the comments as well, but that pretty much wraps up the questions and tonight's presentation. So again, Luke and Ted, thank you so much for your incredible wisdom and time and sharing it with us. I'm sure there's going to be a lot of other questions afterwards. Please get in contact with us if there is. But yeah, ladies and gents, thank you so much, and we look forward to hosting another webinar soon on another subject. So thank you so much.
Yeah, it's a
Cheers,
pleasure.
guys.
Thanks, Jason. Thanks, Ted.
Thank you, Jason. Thanks, Luke.
Jackie.